Okay, well, I'll be presenting the last talk on sutureless valves. My name is Michael Borger from Leipzig. And the question was, are we using too few sutureless valves in the UK? I don't work here and I don't live here, so I can't answer that question. And I don't want to answer that question. What I just want to do is show you the data that's out there, and then you decide if too few or too many are being used in the UK. These are my disclosures. The honorary and consulting fees go to the hospital, not to me. This slide you've seen many times, just showing the rapid growth in TAVI in Germany, which has been duplicated now in the US and is also starting to reach these sort of levels in the UK, but not nearly as high. So in 2018, we were up to 57% TAVI compared to conventional aortic valve, and the number of conventional aortic valve operations reached their peak in 2012 and have been steadily going down since then. So, you know, this is a rapidly evolving area, and if we as cardiac surgeons think that we can just keep doing the same thing that we've been doing for the last 50 years for the next 50 years, I don't think that's a very smart strategy. And one of the things that is different, and although it's been around for a very long time, is minimal invasive aortic valve replacement. And there is some good data, some good class 1 data showing that the minimal invasive approach has some benefits. Here's German data again, just showing the increasing percentage of minimal invasive procedures here in green over time for isolated AVRs. But even in Germany, where we're quite aggressive on minimal invasive surgery, we're still only about 35% of these operations being done with either a upper hemisternotomy or a right anterolateral thoracotomy. So there's still some room to increase that number, definitely. This is a paper that you've seen before from 2008 from Imperial College, and basically it had a kind of a funny title: "Is it worth it, minimal invasive aortic valve replacement?" When you look at the data, though, their data would suggest, well, yeah, it is worth it. There was a survival advantage for early perioperative survival associated with minimal invasive aortic valve surgery in this meta-analysis, and this was statistically significant. And as well, there was significantly lower ICU and total hospital length of stays, as well as ventilation times. However, there was a penalty to be paid, and that was higher cross-clamp and cardiopulmonary bypass times, probably because of the increased technical demands of these procedures. We also in Leipzig looked at the long-term outcomes, so those were short-term outcomes. Long-term outcomes, we did a propensity matched analysis. Of course, this is not perfect science. They're still subject to selection bias, of course. This is not a randomized trial. However, we found that the patients that underwent minimal invasive surgery had much better survival when univariate analysis and after propensity matching, still a statistically significant benefit compared to full sternotomy. I'm not here to tell you that a little mini sternotomy saves lives. That's not logical. But I am here to say that you can perform the operations just as safely and effectively through these smaller incisions. So sutureless valves are actually not new. They've been around since the late 1950s. First generations didn't work so well. They found them in the descending aorta shortly after the operation, which is not a good thing. But the lessons that we learned through TAVI and through the advanced stent technology led the industry to reapply that new technology to an old concept. And so why would we want to use these sutures? Well, they can facilitate minimal invasive surgery. As I said, there are some benefits. As I already showed, I think there's increasing patient demand for these lesser invasive procedures. However, there's still decreased penetration within the cardiovascular community, so room to improve. These devices are also associated with decreased myocardial ischemic time, which may be particularly important for patients that are undergoing complex multi-valve or combined procedures, or those with a poor EF. And then, as I said, that the new stent technology, or not new, but it's been over 10 years now, has very well shown that a stent can hold a valve in place without risk of embolization. The Medtronic Enable, or ATS, original name of the valve, has been withdrawn from the market, but was the first to get CE mark approval. And then came, it still says Sorin here, it's now called LivaNova. And then the last one was the Edwards Intuity. The question is, do they actually facilitate minimal invasive aortic valve surgery? Well, there is data to show that yes, they do. I'll get back to that in a minute. The Levanova Perceval valve looks like this. You all know it. It does have these nitinol stents that extend a bit higher, and therefore you have to make your aortotomy a bit higher and transverse. And there's been more than 20,000 implants. There's sizes that cover basically all of the human anatomy variants. And there is now up to 10 years follow-up with this valve. This is a valve that is very simple to implant because it is folded together and attached to this delivery device. You can look around to make sure that it is positioned in the right place with the annulus surrounding the device before releasing it. The release is quite simple, two-step procedure. But as I said, you do have to make your aortotomy higher, which can make it sometimes a bit challenging with patients' anatomy. This is one of the biggest studies. This is a combined experience out of Paris and in Hannover, 200 patients, what we would now call a low to intermediate risk group of patients, an intermediate risk group of patients. They had an overall mortality of 2.4%, and they found very short cross-clamp and cardiopulmonary bypass times, severe perivalvular leak rate of 4%. And something that was new at that time, but now is well known, is that the transvalvular gradients on these valves were very low. They were in the single digits. And this applies to all three of the sutureless valves. Getting back to Torsten's comment that it's really up to the surgeon to get the best performance out of a valve, I couldn't agree with him more. One of the ways that you can really easily screw up the patient's left ventricular outflow tract is if you have different distances within your plegited suture on the annulus than on the sewing ring of the valve. And especially for younger surgeons that are just kind of learning the technique, this is very easy to oversee, that they don't notice, oh yeah, down here I've got 8 millimeter within the suture, and up on the sewing ring I've got 4 millimeters. And of course you're going to distort the LVOT, you're going to make it smaller, and that's the reason I believe that a continuous suturing technique where that's avoided, or single interrupted sutures, are associated with lower transvalvular gradients. But the same sort of analogy applies for the sutureless valves. There is no way to distort the annulus with your plegited sutures. So the Edwards Intuity combines the well-known long-performing platform from their Magna Ease group of valves, combined with a stainless steel stent, which came from the original Sapien valve, in addition with a polyester cloth, which is meant to minimize the paravalvular leak rate. Important to note that the sealing occurs in the LVOT down at this level. It doesn't occur at the sewing ring level like it does for a traditional valve. So sometimes you'll see on echo little bits of flow going around the annulus, and the echocardiographer will be going, oh, hang on, is that a paravalvular leak? Is that a paravalvular leak? But if you do a deep transgastric view, you will see that there's no flow going into the left ventricle. That's because it's going around the sewing ring, but here it stops. Okay, just so a small point. This was one of many studies. This was from the original Triton trial. Again, the question, does it facilitate minimal invasive surgery? Well, I guess I would let you decide based on, see if that video runs. Can we maybe click on it? See how we're doing for time here. Is it possible to click on that video? Doesn't want to seem to run.
My video didn't run either.
Okay, well, it ran in the speaker ready room. In any case, the one really important thing about the Edwards Intuity Elite valve is that it is sort of obstructing your view of the patient's annulus once you lower it down into place. So there's two things that you need to do. One is you make your aortotomy down into the non-coronary sinus. That helps with exposure. So it's a hockey stick aortotomy rather than a transverse aortotomy. And the other one that's really, really important is the 3 anchoring sutures that you place around the annulus should come up at least 5 millimeters above the annulus, coming out on the aortic wall. And then you want to make sure that you see for all 3 of those guiding sutures, you want to see them exiting the aortic wall, and then you know 100% for sure that the valve is sitting down deep enough in the right position. You can go ahead, blow up the stent, it takes 10 seconds, and then close the aorta and the operation is finished. And you will not have a paravalvular leak as long as the sizing was done correctly. So we looked at this. This was the first generation of the Intuity valve. In this randomized trial, it was 5 centers in Germany. 4 centers had never used the valve before, so this takes into account the learning effect. But despite that, when we randomized patients to a small upper hemisternotomy with the first generation Intuity versus a full sternotomy, where we know from that meta-analysis I showed you that about a minimal invasive sternotomy has a 15% penalty for the cross-clamp time. In our randomized trial, we actually showed a 24% reduction in the cross-clamp time. So there's a 40% reduction altogether in cross-clamp times, which is a marker for facilitating the ease of implant. So we felt that this technology really does facilitate implants, and this is a much more mature series, all minimal invasive, all upper hemisternotomy from Strauss group in Bremen. They had 60 minimal invasive upper hemisternotomy, 1.7% mortality rate, and a really astounding valve implant time of 9 minutes and cross-clamp time of 26 minutes, even though they're all minimal invasive. So this just shows as you start using the technology more and more, you get more and more proficient. And another side effect that we saw is that the mean transvalvular gradient was lower in these valves, statistically significantly lower compared to the conventional, even though most of these conventional valves were perimount valves. So that it's, again, the same valve platform, but better hemodynamic performance, of course, related to the implantation technique. And we also found a statistically significant improvement in patient prosthesis mismatch. This is a systematic review which looked at all sutureless valves, rapid deployment valves together in one study, 1,000 patients, low cross-clamp cardiopulmonary bypass times, very acceptable mortality rates, and also a low major paravalvular leak rate. That's not to say that the news is all 100% good with this valve. In the FDA approval trial called the Transform trial, they again demonstrated reductions in operative times when they compared them to the STS database. But what they also found was that the perioperative outcomes were excellent, 0.8% mortality rate perioperatively, which was fantastic for several hundred patients. But what they also found was quite a high early postoperative pacemaker rate, so 14%, which was a lot higher than our European experience. In the early German experience, we had a 6% pacemaker rate. And we tried to figure out why are they implanting so many pacemakers in the United States. 2 things. Some centers had left bundle branch block as an indication for pacemaker, which is very controversial. I know in our center we don't put in a pacemaker for left bundle branch block. But the other thing is they put them in very early. A third of the patients got their pacemaker within 3 days, which I think most of us in Europe wouldn't do. Paravalvular leak rate is also a bit higher than it is for conventional open bioprosthetic valves. Having said that, I can honestly say I have not had a paravalvular leak for at least the last 50 of these that I've implanted. If you size properly, and sizing is really, really key, just take your time on the sizing. Don't rush the sizing. You will not get a paravalvular leak. And then lastly, I just want to show that these valves can be very helpful for multi-valve procedures, which are increasing in all developed countries. And this is an example where there is a prosthetic aortic valve already in place. It's a perimount, and then we're just, there's a prosthetic mitral valve in place here, biological perimount sitting down below, and above it is an Intuity valve. And it's a nice way to save 20 minutes of cross-clamp time on these complex procedures. And then finally, there are 2 studies showing sutureless versus TAVI valves in intermediate risk, and what they found is that they are both reasonable options, but the sutureless valves have a lower paravalvular leak rate. Both of these studies basically came to the same conclusion, same hemodynamic performance, lower paravalvular leak rate. And then this very interesting study from Milan, 200 propensity match patients undergoing conventional open bioprosthetic valves versus sutureless valves versus TAVR. Again, selection bias, this is not randomized, but they found better results, 2-year freedom from MACE in the sutureless and conventional valve patients compared to TAVR, and concluded that their data does not support routine use of TAVR in intermediate risk patients. The NICE guidelines reflect this. They say, okay, it is an adequate option as long as there are all the usual arrangements in place.
Patient selection should be done by a multidisciplinary team. Specific training is recommended, including mentoring for the first couple of implants, and the results should be submitted to a nationwide monitoring register. So in summary, minimal invasive aortic valve replacement has several benefits, but penetration remains relatively low. The rapid deployment sutureless valves facilitate minimal invasive approaches and may also be a option for TAVI and intermediate or low risk patients. The early and midterm results are good so far, but long-term data is required, and more widespread use may be justified in the UK. Thank you very much.